If you look at all the definitions of hypertension, there's no obvious definition of hypertension in dialysis patients, and so the default is to go with what the standard definition is, which is 140/90 or higher. The difference is the mechanisms contributing to the hypertension and the time of when to measure hypertension, blood pressure, I should say, for determination of hypertension. The usual approach is to bring somebody into the office, have them sit for 5 minutes, and which you should be doing, that's not what happens, and then put the appropriate cuff around them, let them rest for a couple more minutes, and then measure the blood pressure twice. Take the average and go from there. In dialysis patients, if you do that, you can get all kinds of crazy readings because the volume status of a dialysis patient is the key determinant of blood pressure. There's some excellent data that has evolved over the last decade from Rajiv Agarwal that clearly suggests that the optimal time to measure blood pressure is at home the morning after dialysis. Usually what happens is you come into the dialysis unit and they measure the blood pressure right there, they'll measure it again at the end, and off you go. And so you get a real mishmash of blood pressures with the assumption that volume's irrelevant, which unfortunately it isn't. So when you look at hypertension in dialysis patients, it's not that different than it is in non-dialysis patients, but the sympathetic nervous system plays a major role in dialysis patients, and volume, i.e. sodium, plays an even bigger role in dialysis patients than it does in people that have normal kidneys or reasonable kidney function. And the reason sodium is important is because a related system, the nitric oxide system, is really dysfunctional in dialysis patients. And so if that system is dysfunctional, one of the key results of that is that you become salt sensitive. So a little bit of salt will dramatically cause increases in blood pressure, contribute to blood pressure variability, and that is not good for stroke and for other cardiovascular risks. And that's very prevalent in dialysis patients. The data and my experience are pretty similar, and that is you will make a dent in lowering blood pressure, and you don't need to reduce the dialysate dramatically. I mean, if you take it down to 138, 137 from 140, you will definitely have an effect. But we're talking in a range of somewhere on the low end 4 millimeters, on the high end maybe 7 millimeters. It's not a huge change, but sodium intake is as powerful, if not more powerful, in dialysis patients as the dialysate sodium. And the reason is because the dialysate sodium is limited. You're going to be off dialysis within 12 hours. If they decide to go out and have Popeye's chicken, they're toast. Okay? Whereas if they really consistently do that, A, they get more effective ultrafiltration and better dialysis, and they're far less likely to cramp. So I think it's critically important to counsel dialysis patients, and education goes a long way because it will help them participate in their own care. You want people to be informed, to not be afraid to ask you questions about sodium in the diet, because it is important. It does contribute not only to hypertension, but to more fluid retention and more variability of blood pressure, which you really want to avoid at all costs. So lisinopril has been around for many, many years. Now, lisinopril has very, very little data. In fact, I can count on one hand the number of cardiovascular data papers exist with lisinopril. There's far more with other ACE inhibitors, but that's what's used. Now, the other thing is everybody thinks lisinopril is really great in dialysis patients. And there was a study that was done, single center study, but it was done looking at mortality, comparing beta blocker, atenolol, to lisinopril. And it simply looked at body counts. And of course, the person presenting the paper asked for a vote, because it was a late-breaking trial, And 85% of the audience raised their hand saying lisinopril would be the winner. And of course, they lost all their money because atenolol was the winner. And so why is lisinopril not really very good in dialysis patients, whereas beta blockers may be better? So what kills dialysis patients? Heart failure and sudden death. What evidence is there that ACE inhibitors do anything to either of those things? Not much. So beta blockers really are, and of course we go back to mechanism, sympathetic tone. ACE inhibitors do nothing to sympathetic tone. So I think it's important to keep in mind there's a reason certain classes of drugs would work better in dialysis patients, and you can't extrapolate from the general population of the dialysis patient. The patients that get referred to me are all the patients that they can't control. And of course, the number one reason they can't control them is they're still volume overloaded. But once you take that out of the equation, then if you look at the cocktail of medicines that are being used, it doesn't really make a lot of sense. So what am I talking about? Combining a beta blocker with clonidine. If you did that to a normal person that's got normal kidneys, and something bad happened, we'll see you in court. It makes zero sense. And as a friend of mine says, it's directing traffic on a one-way street. You interrupt sympathetic tone up here, but just in case a molecule of norepinephrine got out, you're going to block it out here. Doesn't make sense. Except in a subset of patients that have very high sympathetic tone. But in general, the drugs that are going to be vasodilating are going to give you more mileage in dialysis patients in case they cheated and their volume overloaded. You increase capacitance for fluid. So calcium antagonists are really very good. I know there's some controversy about diuretics, but in the beginning when people start dialysis, I maintain them on loop diuretics so they can at least get some extra fluid out. Beta blockers for reasons that we said. And then really everything else just tortures the patient. So I think you have to choose wisely. The dialyzability of drugs is important. Metoprolol is dialyzable. Atenolol is dialyzable. And actually carvedilol is not that dialyzable, not compared to metoprolol and atenolol. And so the water-soluble drugs in general are going to be dialyzable. The average dialysis patient I see with diabetes is taking on average 14 to 16 different medications a day. Now, I don't care how smart you are. I don't care how compulsive you are. Under the best of circumstances, that's challenging. So you may not get that in surveys because they want to feel better. They want freedom from the dialysis machine. That's clearly going to rank higher than the number of pills they're taking. But if you take those out of the equation, then you're down to fewer blood pressure medications. Every time they come in, these people want fewer blood pressure medications. And when I confront them about the fact that they're not adherent with the fluid intake, they're not adherent with the sodium intake, so they need better blood pressure medications, and I'm writing the prescription for minoxidil, and I tell them, this is going to put hair on your chest, and they think I'm kidding, but then when they see it, it's real, but their blood pressure comes down. And then some of them get with the program and watch the salt, and then they come off. And for them, that's a big thing. So I tell all the patients, if you want to reduce the pill count, the first thing we have to do is absolutely, positively follow the lifestyle modifications that we talked about. And if you do that, there's a good chance, a very good chance, that we'll be able to stop one. That's almost unequivocal. Well, you cannot achieve blood pressure control with all these other options, because if you could, what would be, I said at the very beginning, this is volume. So the most common cause, if somebody gives us, and we get these consults all the time in the hospital, a dialysis patient whose blood pressure is resistant. And 99% of the time we have 2+ edema in these people. And it's not because their albumin is 2. And they're just under-dialyzed. And they've either missed dialysis, or they're drinking 4 liters of fluid daily before they come in. And for whatever reason, they're volume overloaded. And once you fix that, And the house staff is consistently amazed because drugs melt away in that setting. If you do short daily dialysis, that protects you from yourself, because even if you're going to cheat a little bit, we got you the next time. So I'm a big fan of short dialysis, nocturnal dialysis. I think the data is very clear. You get better blood pressure control. I mean, almost having it, it's like 36% better. People feel better. What's not to like?
AdvancingDialysis.org is dedicated to providing clinicians and patients with better access to and more awareness of the reported clinical benefits and improved quality of life made possible with home dialysis, including more frequent, more intensive, and nocturnal therapy schedules. All forms of hemodialysis, including treatments performed in-center and at home, involve some risks. In addition, there are certain risks unique to treatment in the home environment. Patients differ, and not everyone will experience the reported benefits of more frequent hemodialysis. Certain risks associated with hemodialysis treatment are increased when performing nocturnal therapy due to the length of treatment time and because therapy is performed while the patient and care partner are sleeping. AdvancingDialysis.org is a project of Next Stage Medical Incorporated.